但是这也不会找到我。
Mama?
Hello, everyone from Asia and to all our audiences around the world, especially to our friends in Palestine. This is CPD Asia, the online continuing professional development platform for Asian radiologic technology societies. And hosting the 54th CPD Asia program is the Palestinian Association of Medical Radiation Technologists, PAMRT. I am Pichi Luna, CPD Secretary General, and your CPD Asia program host. We are live streaming on YouTube. You can search MSR, PARI, and the VART channels, or you can just search CPD Asia. You can join us live or watch a replay anytime. Now, to formally start the program, may I call in President Mohammed Abdelghani of the Palestinian Association of Medical Radiation Technologists, PAMRT, for his welcome message. All right, so while we are waiting for President Mohammed Abdelghani, we would like to extend our heartfelt appreciation and warmest welcome to all the presidents who are joining us live here, to their officers and representatives, and also our invited panelists joining us from various member radiologic technology societies across Asia. Let us greet and welcome. We have here President Mr. Nam Tak Meng of Hong Kong Radiographers Association.
Good evening, everyone. Nice to meet you and enjoy to live the webinar.
Yes, we have Sir Jerry Lay attending for President Koch of Macau Radiological Technologies Association. And we also have Chair Chin Chun Yu from Macau Association of Radiologic Technologists. Attending for President of Vietnam Association of Radiological Technologists is Mr. Lu Tri Dung. We hope to hear you, sir. Please unmute your microphone.
Sorry, everyone. Vijay, can you hear me?
Yes.
Thank you. And good evening to everyone. I'm honored to be here to represent for Mr. Taiwan Lao, President of Vietnam Association Radiologic Technologists. And I'm very honored to be here with you on and wishing the CPD by Palestine will great success. Thank you.
Thank you. And also attending with us is President Chun Yuan-Tu of the Taiwan Association of Medical Radiation Technologists.
Good evening, everyone. Nice to meet you.
Yes, good evening there, sir. We also have here Chair Cora Nang of Macau Radiological Technologists Association.
Good evening, everybody. Welcome to the 54 Asia CPD. Nice to meet you.
Yes, we also have President of Malaysian Society of Radiographers, President Sawal Marsait.
Everyone, good evening. Hello, thank you.
Yes, good evening there in Malaysia. And I think we have already here, yes, President Vitarana Gomez Wimalasena from Society of Radiological Technologists.
Hello, good afternoon, good evening, everybody. And nice to see you all. And congratulations to PAMRT. Thank you very much. So I will hope to have a good webinar. Thank you.
Yes, thank you. And also from Indian Society of Radiographers and Technologists, ISRT President, Mr. President Mohan Lal Bhagwat.
Good afternoon and welcome to 54 CPD Asia Palestine webinar on advanced and diagnostic medical sonography from basic to clinical practice. And I extend my heartiest best wishes for the all success to the entire team. Thank you very much.
Thank you, President of ISRT. We have received greetings also from President of Singapore Society of Radiographers, President Denise Chung, from President Sophie Lee of the Association of Cambodian Radiological Technologists. Of course, we have received also greetings from President Katsuhiko Ueda of Japan Association of Radiological Technologists, from President of Philippine Association of Radiologic Technologists, President Ruben Lorenzo. And I think we also have here a president of Taiwan Society of Radiological Technologies, President Kui Yuan Wu. Are you here? And of course, we would like to greet our invited panelists who are joining us live here. We have Sir Nelson Wan from Hong Kong. We have past immediate president of ISRT, Mr. Salva Kumar.
Namaste. Greetings from India to all the panelists and all the members of this CPD. Namaste,
Yes.
sir.
Namaste.
Our heartfelt congratulations to the Palestinian Association for bringing the wonderful topics today. It's a new topics. So far in CPD, we are not touching these topics, ultrasound and other things. So nice to hear. We are awaiting to hear the same. Thank you.
And attending for President Dr. Gek Sugianto is our invited panelist from Indonesia, Putu Adi Susanta. All right, so I guess we're ready to hear the message, the welcome message of our dear president of the host society from Palestine, President Muhammad Abdelghani of Palestinian Association of Medical Radiation Technologists. President Muhammad, are you there now?
Dear distinguished presidents, esteemed colleagues and honored attendees, on behalf of the Palestinian Association of Medical Radiation Technologists, PAMRT, it's my great honor to welcome you all to the 54th CPD Asia. Today we gather not only as professionals in the field of medical radiation sciences, but also as partners in a shared mission to advance knowledge, to strengthen collaboration, and to ensure the highest standards of patient care across Asia and beyond. It brings me special pride to that Palestine, through PAMRT, has the opportunity to host this important platform. Despite the challenges our country encounters, our unity as radiographers reminds us that sciences and education know no borders. Together we stand as one community dedicated to learning, innovation, and professional growth. I would like to express my appreciation to the leaders and societies joining us today, and to every attendee who has taken the time to participate. Your presence here is a proof of the dedication and passion that drive our passion forward. Let us use this meeting to exchange experiences, to inspire each other, and to strengthen the bonds that unite our societies. I am confident that today's discussions will contribute meaningfully to the development of medical radiation technologies across our region. Once again, welcome to this important event. Thank you for being part of this journey, and I wish you all a productive and enriching meeting. Thank you and welcome.
Thank you so much for that very warm welcome, President Muhammad Abdelghani of the Palestinian Association of Medical Radiation Technologists. Now, as you know, before we begin the session, I would like to humbly request all our presidents, officers, and their representatives, along with our speakers and our invited panelists, to please open your cameras for a very brief photo session. All right, one more. All right, so again, thank you so much to our dear presidents and officers and our invited panelists. They will be joining us again later during the Q&A session. So now for today's program, we're honored to have three distinguished speakers join us to share their expertise in ultrasound imaging and cardiac diagnostics. Let's begin our session. Our first speaker is Professor Mustafa Aweiss, Head of Medical Imaging at Alquds University. His presentation is titled Using Ultrasound Probe Pressure to Move Free Gas. Free gas, all right. So please join me in welcoming Professor Aweiss.
Peaceful greeting from the Holy Land, from Jerusalem, and from the Dome of the Rock, to everybody, to everyone all over the world. Today I'm gonna talk about using ultrasound probe pressure to move free gas. In 1993, I did apply ultrasound probe pressure to move free gas in Brooklyn, New York, USA. At that time, nobody told me I could use pressure to move gases. I did prefer to scan the patient transpelvic, which is an external scan of lower abdomen rather than scanning the patient transvaginally, which uses an internal probe. I did most of the time use transpelvic scan because we have a lot of patients coming to see the pregnancy and first trimester pregnancy. So I don't like to use the endovaginal. Sometimes I have to. I have no choice to see better visualization of the uterus and the ovaries. I have been successful in 1993 in most cases in getting the correct diagnosis and even finding ectopic pregnancy in the fallopian tube. Gas obscure the underlying anatomy. We cannot see the anatomy because of the gases. Gas is a significant limitation. It is a contraindication for ultrasound scan. We see gas, we don't see structure, we don't see anatomy. So we need to find a way to move the gases away. Moving gas is important to improve visualization of the structure. Sound wave don't travel well through air and gas. Why? Because gas molecules apart, separated. It's not solid area, solid structure, solid organ. Probe pressure can be used to rapidly move the gas. We can apply pressure to move the gases away. How to use this technique? By positioning the probe on the patient. Start looking if there is artifact inside the patient. We apply pressure. If there is no gases, we don't apply pressure. We see and we start scanning. But if there is artifacts and gases, we apply pressure. We see what we have to see. We do the scan, the ultrasonography scan, and then we release the pressure and finish the scan. Pressure will cause the gas to move, as similar to curtain, as we see on the left. Looks like a curtain. In the middle, we see a sonographic image which has gases on both sides. It's moved, and we can see the structure underneath the gas. Looks like a scissor when you open the scissor. Pressure should only be attempted if patient does not have a significant pain. Don't use pressure if patient have pain. Patient must be comfortable when we do the scan. Also, probe pressure is effective when or to differentiate between free and bowel gas. Gas prevents transmission of ultrasound waves and creates reverberation artifacts. As we can see on the right, there is reverberation artifact caused by a needle, biopsy needle. On the left, we can also see a revibration artifacts. Free gas can also be moved with patient position. Why only one position? All sonographers use a supine. They don't want to move the patient. But we should be more practical and move the patient. We can try all kinds of positions, whether it is recumbents or even standing or seated. We can scan patient supine, but also to move the gases. We can put the patient in a prone position or right lateral decubitus to scan the left side of the patient, to scan the kidneys and the spleen. Or we can do the left lateral decubitus. So also we can use the oblique position, right posterior oblique and left posterior oblique. The gases will tend to move up and we can scan the organs. Also, we can use a seated position or standing position. In some books and articles, they prefer hands and knees position, which will move the gases. In addition, it will move the stones in the gallbladder. Movement of patient used also to differentiate between gas and the bowel within the abdominal cavity. Free gas will not be seen while scanning intercostal. So we should use this technique to see great images. As we see on the right side, we can see the liver, we see the hepatic, and we can see the portal, we can see the IVC very nicely without seeing any gases. Fasting is very important to improve visualization of structure. We should ask the patient to be fasted 8 hours before the examination. On the right side, we see the gases from the intestinal, but on the left, we can see clearly the pancreas and the tail of the pancreas, which is hard to be seen. The sonographer should be very good sonographer to see the tail, and always we can see gases on the tail, but with a good scan and good preparation of the patient, we can see the pancreas, the whole, the head and the tail very clearly seen. Water also can be used to reduce gas. We can ask the patient to drink water and fill the stomach. As we see, the stomach will be very nice window the spleen and the kidneys, using water in the stomach as a way, as a window to see all the structures on the left. If a filled urinary bladder also does not produce gases, we need to fill the urinary bladder with urine. We ask the patient to drink slowly and drink cups of waters, warm water, not gassy or juice, just water to fill the urinary bladder. And we can see the uterus and ovaries in the pelvic area. Also, with male patient, we can see the prostate gland. Urine used inside the urinary bladder to provide an acoustic windows or window that improve visualization by pushing gas-filled bowel loops out of the way. We cannot use pressure when the patient has severe abdominal pain, which limit the study because of the tenderness. So we have to be very careful with using pressure. For examples, we should not apply additional ultrasound pressure. We can apply small, tiny pressure to move the gases, or we don't use pressure when the patient has appendicitis. Also, we should not use additional probe pressure when the patient has cholecystitis. As we can see, the thickened wall of the gallbladder and may also cholecystitis has stones impacted in there. So we should not apply pressure or too much pressure, just a little bit to see the gallbladder. Also, we should avoid applying additional ultrasound pressure on the spleen when it is enlarged. Splenomegaly can be ruptured. The spleen can be ruptured if we use a pressure. So don't use that pressure there. So try as is. Try to work as is. Don't hurt the patient. Also, if there is aortic aneurysm or aortic pathology using pressure, I don't prefer it there on the abdominal area. When the patient has severe abdominal tenderness or rigidity, we should not apply too much pressure on the abdominal area. Also, if the patient has severe pelvic pain, especially women, we should not use too much pressure. Don't use ultrasound pressure on the ribs. Very, very painful and tender. When we apply the pressure, especially near the ribs angles. So when we scan intercostally, as we saw before, we should be very, very careful and don't apply pressure. Also, near the xiphoid, please avoid pressure. It can be very painful when you apply a pressure on the xiphoid. Please scan lower. Scan in the cavity, abdominal cavity, and be careful. Also, don't go down and so don't use the pressure on or near the iliac crest. When to use it, where to use it. The location is abdominal cavity is the key word. Abdominal cavity, where all the organs situated, we can apply pressure to move the gases. In the cavity, there are organs we need to see and scan. So pressure is very good to be used in there. Don't use it up near the ribs or the angles of the ribs or near the xiphoid or near the iliac crest. Stay in the cavity or within the cavity. Also in the pelvic area, we can use pressure in male and female, but always scan near the hairline and apply pressure without causing any problem to the patient and pain. Look at the patient face. If there is pain, stop applying pressure. You have to be very careful to get the information and be as gentle as you can. Degree or level of pressure used. Don't use any pressure if you can see the structure very clearly. You can use low pressure as needed, or medium pressure, or very high pressure. This depends on the size of the patient. we have to use pressure according to the body habitus. Asthenic patient, sometimes you don't need, no pressure is needed. Obese patient, as we can see from the size, thin patient, no pressure. Big patient, yes. You need to dig. You need to dig to see the structure. Also, pressure used according to the age. Don't use pressure on neonate or children. Their organs will pop and you will see it very clearly without any pressure. But when the patient age is get bigger and you can see, for example, 30s and 40s, the patient got that momentum, big momentum, obese, and start. We need that pressure. We have no choice. Obesity is really, with ultrasound, too much. We need to use pressure. So as we see on the right side, on that photo, there is folds. So you have to go underneath the fold to scan the patient. Fold it up and scan the pelvic. Or you have to fold it to the side and start scanning. You cannot scan where there is a lot of skin folds. Try as much as you can to move all the folds and use pressure. From my heart, I would like to thank you all.
Yes, thank you, Professor Aweiss, for that insightful presentation. Your demonstration of how probe pressure can manipulate free gas offers a promising implications for improving diagnostic clarity and patient outcomes in abdominal imaging. So now we have our second speaker. Our second speaker is Mr. Adham Abderrazeq, a cardiac imaging specialist from Al-Najah Hospital. His topic is Introduction of Cardiac Echocardiography. Let us welcome Mr. Abderrazeq.
Hello everybody, my name is Adham Abderrazeq, Senior of Echocardiography at Al-Najah National University Hospital in Palestine. Our literature about Introduction to Echocardiography. The main aim of our literature is started off anatomy and physiology of the heart pumping stage, a simple physics of the ultrasound, transthoracic echo, and indication of transthoracic and transesophageal echo, cardiac ultrasound operation and how to imaging. Finally, we discuss a common echo pathologies. Now, we talk about the anatomy and physiology of the heart. The heart is located in the mediastinum between the lungs inside of the pericardium. The size of the heart is fist-sized and the weight between 250 to 350 grams. The heart is composed of the 4 chambers, 2 atria, right atrium and left atrium, separated by interatrial septum, and 2 ventricles, right ventricle and left ventricle, separated by interventricular septum. There are 2 circulation of the heart, systemic circulation and pulmonic circulation. The pulmonic circulation is start when the right atrium receiving the deoxygenated blood from the superior and inferior vena cava and coronary sinus, pumping the blood toward the right ventricle through the tricuspid valve. After that, the right ventricle is pumping blood toward the pulmonary through the pulmonic valve. The deoxygenated blood is reached to the pulmonary and exchanged to the oxygenated blood. The oxygenated blood is back to heart through the pulmonary vein. There are 4 pulmonary veins, right and left upper and lower pulmonary vein. When the oxygenated blood reaches the left atrium, it's pumping toward the left ventricle through the mitral valve or bicuspid valve. In systole, the left ventricle pumping the blood toward the aorta through the aortic valve and start of systemic circulation. There are 2 main coronary arteries supplying the blood to the heart muscle: left main coronary artery and right coronary artery. The left main coronary artery supplying the blood to the anterior heart and the left side of the heart. They are divided to the 2 branches: circumflex artery and left anterior descending artery. And the right coronary artery is supplying the blood to outer side and back of the heart. Cardiac pumping stage. There are 2 stages of the heart: systole and diastole. The systole stage, the heart is contract and pumping blood out. Diastole, the heart is relaxed and filling the blood. There in the ECG, the B wave is the atrial contracting, and QRS is the ventricular contracting. The T wave is the ventricular relaxation. Physics of the ultrasound. The human hearing range between 20 Hz to 20 kHz, and the medical imaging use range between 2 to 15 million Hz. It's above of human hearing range. The transducer function. The transducer have 2 functions: sending and receiving of the ultrasound. The transducer is sending of the ultrasound hit of multiple structure of the body, and after that the transducer is receiving this ultrasound and create a real image on the screen. The ultrasound is safety and very comfort for use, no ionization radio. There are 3 main applications of the echocardiography: 2D image, Ammud and Doppler. The 2D image shows the real cross-sectional image of the heart, shape, size and movement. Ammud measure of the heart structure as we seen here for measure the aortic root and left atrium, or motion of the heart as we see the systole and diastole motion of the heart. There are 4 types of the Doppler: pulse Doppler, continuous Doppler, color Doppler and tissue Doppler. The pulse Doppler is used for measure the velocity of the blood at the specific point of the heart. Continuous Doppler used for measure the high speed of the blood velocity, helpful for evaluation the stenosis and regurgitation. Color Doppler add for shows direction and speed of the blood, easily for detecting the regurgitations. And finally, tissue Doppler measure the heart muscle movement. What is the TTE? TTE is the abbreviation of the transthoracic echo. It's a quick bedside ultrasound of the heart using for evaluation heart function, hemodynamics and pathology as a valvular lesion, chamber size, effusion, ejection fraction and others. There are 3 types of the echocardiography can be done: transthoracic echo, transesophageal echo and vitamin stress echo. The transthoracic echo, this probe used in the transthoracic echo, it's non-invasive examination and a play probe on the chest. The transesophageal echo is the invasive procedure. This probe used for transesophageal. The probe is induced toward the esophagus and need special preparation as the patient fasting and needs sedation. The vitamin stress echo is the same of the transthoracic echo, but this examination is done with medication named dobutamine. What is the indication of the cardiac ultrasound? There are many indications for cardiac ultrasound. ECG changes for evaluation the left ventricle function, chest pain, palpitation, shortness of breath, hypotension, pericardial effusion, and new murmur for the valvular lesion and intercardiac shunt. What is the indication of the transesophageal echo? The transesophageal echo is done for many indications as infective endocarditis, for seeing the vegetations attached to the any valve of the heart, a prostatic valve assessment. The transesophageal is done for see the stuck valve thrombus attached to the valve, paravalvular lesion, aortic disease as dissection and aneurysm, Stroke is very important transesophageal echo for evaluation, the intercardiac shunt of the heart, congenital heart disease, intraoperative monitoring, poor TT image because of obesity and lungs disease. Cardiac ultrasound preparation. There are two main positions of the patient. Patient is supine flat, it's the first position, and the second position is left lateral decubitus as we see in this image. The left lateral decubitus is increase the quality of the image because the heart is become more contact to the chest. The standard echocardiography view is parasternal long axis view and parasternal short axis view, apical view, and subcostal view, suprasternal view. Parasternal long axis view is the first view done for patient used for evaluation ejection fraction, left ventricle and right ventricle size. The probe induced at the left of the sternum between the fourth and fifth intercostal space, and the marker of the probe is facing toward the right shoulder. This is the parasternal long axis view. This is the right ventricle, interventricular septum, left ventricle, mitral valve, left atrium, aortic valve, ascending aorta. This view is important for evaluation the motion of the left ventricle, inferior lateral and septal, measure the right ventricle size, noted the opening of the aortic valve and mitral valve anatomy. After that, the color Doppler is applied for the parasternal long axis view for seeing the aortic regurgitation, mitral regurgitation, intracardiac shunt. Now we talk about the parasternal short axis view. From parasternal long axis view at the same position, only rotate the probe 90 degrees to become the landmark toward the left shoulder. In this position, we can obtain 4 images. First image is the short axis of the aortic level. In this image can be obtained from the parasternal short axis view, only tilting up the probe to become the probe at the level of the aortic valve. This image is appear. This is the aortic valve, right atrium, left atrium, interatrial septum, tricuspid valve, right ventricle outflow tract, and pulmonary valve, main pulmonary artery. Apply the color Doppler for see the tricuspid regurgitation, pulmonary regurgitation, intracardiac shunt, aortic regurgitation. Only after that, sweep the probe 1 cm anteriorly to become at the level of the pulmonary valve and the bifurcation of the pulmonary valve. This is the left pulmonary artery and right pulmonary artery. This is pulmonary valve, main pulmonary artery. Apply the color Doppler for see the regurgitation or stenosis. After that, focusing of the aortic valve for see the number of the aortic valve cusp. This is the left coronary cusp, right coronary cusp, non-coronary cusp, Mercedes-Benz side. From short axis view, we tilting the probe inferiorly to become at the level of the biliary muscle. This is the short axis, left ventricle and right ventricle. This is the interventricular septum, anterior wall, inferior wall, lateral wall, papillary muscle, 2 papillary muscle, posterior lateral and posterior medial papillary muscle. Continue tilting the probe inferiorly and sweep the probe 1 cm toward the apex to become at the level of the mitral valve. This is the short axis of the mitral valve, fish mouth view. This is the anterior leaflet and inferior leaflet of the mitral valve. Continuous tilting inferiorly of the probe and continuous sweep of the probe inferiorly to become the level of the apex of the LV. This view is appear. The third view of echocardiography is the apical view. The apical view is obtained by position the probe of maximum bolus area. This is area inferior to the nipple and the landmark toward the 3 o'clock. In this position, we can obtain 4 view by tilting and rotating of the probe. The first view can be obtained is apical 4-chamber view. This is the apical 4-chamber view. Left ventricle, right ventricle, interventricular septum, intraatrial septum, left atrium, mitral valve, and right atrium tricuspid valve. Apply the color Doppler for see the regurgitation and intracardiac shunt in this view. From the 4-chamber view, we tilting the probe anteriorly to obtain the 5-chamber view. This is example of 5-chamber view. The same anatomy, only this is the left ventricle outflow tract and aortic valve. Apply the color Doppler for see the regurgitation of the aortic valve and continuous Doppler as over of the aortic valve to see the velocity across the aortic valve and evaluation the stenosis of the aortic valve. From the 4-chamber view, we rotate the probe 90 degrees to become the landmark toward the left shoulder for obtain the apical 2-chamber view. This is the view obtained is named apical 2-chamber view, only seen the left side. This is the anterior and inferior wall of the heart, left ventricle, mitral and left atrium. 3-chamber view. From the 2-chamber view, we rotate the probe, continue rotate of the probe at the same degree of the tilting to become the landmark toward the right shoulder. This is example of the 3-chamber view. This is named apical 3-chamber view or apical long axis view because it's the same anatomy of the apical of the parasternal long axis view. This is the left ventricle, left atrium, mitral valve, aortic valve. Apply the color Doppler for see the regurgitation and other. The fourth view of echocardiography is the subcostal view. Apply the probe inferior to the xiphoid process and the landmark toward the left side at the 3 o'clock. This is view is appear. This is the liver. This is the 4-chamber of the heart. Important view for see the pericardial effusion. Any effusion can be obtained in this view. Ask the patient to take a deep breath for more evaluation and more clear image. Apply the color Doppler for see the intercardiac shunt of the heart. Subcostal inferior vena cava view. From the same position, only rotate the probe to become the landmark toward the head or above. This view is very important for evaluation the inferior vena cava collapsibility and estimated the central venous pressure. If the inferior vena cava, as this example, is normal size and normal collapsing, the estimated central venous pressure between 2 to 5 mmHg. And this is example of the overloaded patient. The inferior vena cava is dilated and non-collapsing, so the CVP is estimated from 15 to 20 mmHg. The final view of the echocardiography is the suprasternal view. We ask the patient for elevated the head and rotate the head toward the left side. Apply the probe in the jugular notch and the landmark toward the 2 o'clock. This view is appear. This is the ascending aorta, descending aorta, and left LBA. This is the aortic arch. Apply the color Doppler for see the acceleration or coarctate and apply after that the continuous Doppler across the descending aorta for see the coarctation of the descending aorta. Now we discuss the common echocardiography pathologies. This is the first very important things evaluation in the echocardiography is the left ventricle systolic function, ejection fraction. What is the simple explain of the ejection fraction is the volume of the blood in diastole minus the volume of the blood in systole divided to the volume of the blood in systole multiplied of the 100%. This is example of the normal ejection fraction because all wall of the LV is normal thickening in systole and all wall is normal motion. This is the moderately reduced ejection fraction because the septum is no motion, hypokinetic. Here is the example of the severe left ventricle dysfunction because the anterior and septal and inferior lateral is hypokinetic and this motion. Another pathology is discussed in our lectures is pericardial effusion. What's the pericardial effusion? Is a cumulative amount of the fluid between the visceral and parietal layer of the heart. If the amount of the fluid between 4 to 10 millimeter, it's a small pericardial effusion as we see here, and if the amount of the fluid between 10 to 20 is a moderate pericardial effusion, and if the amount of the fluid is more than 20 millimeter, this is large pericardial effusion. As we see here is the right ventricle is compressed. This case is named tamponade and need pericardiocentesis. Another example is for chamber view, small amount of the fluid accumulative, so is example of a small pericardial effusion, and here is a large amount of the fluid, large pericardial effusion. Mitral regurgitation, it's examples of the mitral regurgitation. The mitral regurgitation is occur when the blood is back from ventricle to atria during systole. This is the example of mild pericardial effusion because the mosaic color is less than 1/3 of the size of the left atrium. This is example of severe mitral regurgitation because the mosaic color is more than 2/3 size of the left atrium. This is the severe eccentric mitral regurgitation, and this is example of the moderate mitral regurgitation because the amount of the fluid less than 2/3 of the left atrium size. The final pathology can be detected by the echocardiography is the pulmonary embolism. This is example of the thrombus in the right atrium caused the pulmonary embolism. And another view, this is another review of short axis view, and large size of the right ventricle, T shape of the left ventricle. This is sign of pulmonary embolism. A final sign is Macau sign. Is the lateral wall of the right ventricle is akinetic, no motion, and hyperdynamic of the apex. It's sign of the PE. Thank you. Any question?
Yes, thank you, Mr. Abderrazeq. By the way, for our attendees who are here, you may reserve your questions or key in your questions via the Q&A chat box here, so we can read your questions later for our speakers. So now let me introduce to you our third and last speaker. Our final speaker is Ms. Sewar Shuibat, who holds an MS degree in Bioimaging Sciences from Boston University. Her presentation is titled Ultrasound Advanced Tools and Applications. Please welcome Ms. Shuibat.
Hello, everyone. I hope you're enjoying the sessions today. My name is Sewar Shuibat, Imaging and Ultrasound Application Specialist, and I'm presenting to you ultrasound advancements and tools. Our agenda for the day is going to be about the what and the why, examples from general imaging, obstetrics and gynecology, point of care, and finally finishing strongly with a preview of the future of ultrasound. To begin, let's start by asking, what are the most common areas of advancement in ultrasound nowadays? To meet the expanding medical demands, the common developmental trends across the board are found in the following areas: image quality, automated tools and 3D imaging, artificial intelligence, and portability. Let's digest each area one by one. Image quality. Image quality is controlled by many factors, especially that every patient is different. Even the best of ultrasound systems may fall short when scanning difficult-to-scan patients. Two factors, however, are main players. They are the image processors and the probe technology. What are the imaging processors? They are the processing power in image acquisition, reconstruction, and visualization. Traditionally, the processors used to be hardware processing channels, receiving the sound waves or the beam from the probe, then into the processing channels, and then to be constrained into the hardware beamformer to produce the scanned images. Currently, with the development of the digital channels, we're now able to receive large data coming from the probe into the unlimited channel memory to be then stored and recombined with a software beamformer right here. This provides enhanced contrast and spatial resolution in the images. Moving to probe technology, probes are traditionally made up of lines of crystals, also known as elements. When these elements produce the waves, they produce and receive sound waves that vibrate, laying out heat, and this heat is then creating the unwanted noise in the images. To resolve this problem, latest probe advancements have come to change the concept of the probe. They've changed the crystal's concept into one single piezoelectric crystal layer right here. Not only that, GE Healthcare came to introduce a new building block for the probes. They've added the acoustic amplifier layer right here and the cooling stack right here. So now we have three main elements: the single crystal, the acoustic amplifier, and the cooling stack. So what do? The single crystal is a highly efficient piezoelectric material that exhibits a wider bandwidth than conventional crystals. The acoustic amplifier, on the other hand, it captures and then redirects the unused energy that passes through the crystals to enhance sensitivity and axial resolution, but most importantly, to increase and enhance penetration. Lastly, the cooling stack. This technology is a patented technology by GE Healthcare. This technology relieves the inherent heat that's generated through the probe that otherwise, if it stays, it will reduce the sensitivity and penetration, which we worked hard to get from the other two layers. Combining the two previous advancements together, we're now able to move from an image quality looking like this to this image quality, where it's evident to have improved spatial resolution, contrast resolution, and signal-to-noise ratio, lower noise, higher homogeneity, and lower artifacts. It's also ready for enhanced 3D, 4D processing, crisper images, enhanced color sensitivity, and these images are now more fitted for AI for the large amount of data that was stored into them. Automated tools and 3D imaging. The volumetric images are based off of the 2D images. As we say, if you have a good 2D, then you'll have a good 3D. So utilizing the previous two advancements discussed, now we have higher 3D resolution scans, better real-time 3D images, and the data is better suited for AI applications. The vast amount of data that we're able to process with the high image quality acquired enables for more versatility in the volumetric ultrasound. So as we can see here, crisp images of the uterus, fibrotic uterus, a fetal profile, and a 3D, 4D of the heart. Automated tools, however, are developed through machine learning algorithms. These algorithms are usually based on hundreds of thousands of clinical images introduced to teach the algorithm to recognize with confidence. These tools are used in most areas of the ultrasound these days, and the utilization of these tools in everyday ultrasound practice helps in streamlining the workflow, increasing the consistency among the team, simplifies the complexity of the examinations, increases the reproducibility of the exams, and delivering care for more patients. Artificial intelligence. Leveraging the imaging processors alongside the machine learning algorithms gave AI the capacity to become a transformative force in ultrasound. It is able to analyze tremendous amounts of ultrasound data and eliminate some of the manual human error. Traditionally, ultrasound image interpretations relied heavily on the expertise of healthcare professionals. Given the fact that their expertise will always be the first medical opinion, their interpretations can sometimes be subjective, time-consuming, and prone to human error. With AI, along with the learning algorithms and the data analysis, AI has been taught for pattern recognition, detection of abnormalities, assessing and diagnostic predictions, and providing diagnostic confidence. Meaning, AI-guided ultrasound helps users of all experience levels to acquire reliable, consistent diagnostic ultrasound images, as well as acting as a second opinion in place, fast, reliable, and with fewer repetitions. Portability. Portable ultrasound systems came to answer one important question. How do you provide the right care to the right patient at the right time? In order to deliver timely patient care, vendors have become creative with their portable technologies. Some ultrasound systems have laptop-like designs, others are similar to tablets, and now the handheld probe-like devices. If we take a look at the picture right here, we have this device that has two probes embedded. So here we have the linear probe, and here's our sector array probe. Others, similar to this, would have a convex probe right here and a linear probe right here. This particular device has a wireless connectivity option that can connect the device to any smartphone, tablet, or iPad. Other systems could have wired technology, but they all serve the same purpose. It is to treat patients at the point of care, immediate focus imaging, real-time assessments, fast, wireless, durable, and reliable. This innovation is valuable at the point of care, in emergency departments, operation rooms, intensive care, anesthesia, and on the ground in areas where it's most needed, like Gaza. Now moving to the why. Why is it important to learn and master the advanced tools? It is important in a world of growing demands to catch up with the newer technologies. Ultrasound technologies are coming out by the day, and it is our responsibility to adapt to the constant changes and complexities. It will help us diversify our medical knowledge, get us used to the new technologies and machines, to scan faster with higher accuracy and confidence, and also to unify the workflow along the team of multiple users on the same system, and lastly, to help us with our continuous education. Let's put all the previous technological advancements into practice. I would like to introduce to you some examples of applications, starting with examples from general imaging. The first example we have here is shear-wave elastography as part of the liver care in ultrasound. Shear-wave is a non-invasive imaging mode that provides quantitative measurements of liver stiffness. These measurements are done by taking the speeds of ultrasound waves and then giving us a marker for fibrosis. These quantifications help us in diagnosis, staging, and disease management by follow-up examinations. The patient preparation for this exam is the same as for doing a biopsy, even though it's a non-invasive. Once the shear wave mode is activated, then we will have these two screens displayed. The patient would be laying on the bed right here. The probe is placed in this area right here, which is the exact same one as for the biopsy. And then we have these two images. The first one here is the actual image, and this is a quality indicator, just giving a second opinion to the user whether they're taking the measurements in the right place or not. There are obviously rules for how and when to do the examinations. One of the most important ones is to be away from the liver capsule, at least by 1 centimeter, away from shadows or vessels or anything that has high intensity in nature. The exam should be concluded after acquiring 10 to 12 measurements. It is calculated by kilopascals or meters per seconds, and then finally the final average results and cutoff charts provided by the manufacturer company will give us the final assessment. The second example we have in general imaging is breast assistant tool as part of the breast care and ultrasound. Breast Assistant tool is powered by AI and machine learning to recognize patterns in breast tissue based on more than 400,000 images. If we take a look at the images here, this is a breast scan. This is before starting the Breast Assistant, and this is after. So what does it do? It provides us with a risk assessment aligning with the BI-RADS Atlas category that generates color-coded confidence scale right here to assist in lesion classifications. By one single touch, it automatically generates and contours the lesions, segmenting it and measuring it. The AI then analyzes the lesions to provide the BI-RADS category and the probability scale in 2 seconds only. This supports our radiologists in their diagnosis, especially in the more complex cases. This is supported by many researches. One of them was published by the Digital Imaging and Signal Processing in Medicine and Biology Symposium. It says that KSDS, which is the AI tool used here, that it improved the accuracy in breast cancer diagnosis for radiologists across all levels of experience. This is shown by increasing the sensitivity and the specificity in their diagnosis, as well as reducing the numbers of biopsies needed to do to prove malignancies. Jumping into examples in obstetrics and gynecology. Jumping into OBGYN, the first example we have here is SonoCNS, and this is part of the fetal brain examination. Fetal ultrasound requires users to manipulate images and volumes to find specific planes to investigate the fetal anatomy. This is especially hard when scanning a moving fetus sitting in different positions all the time. SonoCNS is an automated tool that simplifies the workflow and the fetal brain assessment. Instead of acquiring scans of all the required planes, the users need to only acquire a good transthalamus view. The tool then will take care of the rest. It will automatically identify the other appropriate planes and their associated measurements accordingly, as we can see here. We have all the planes identified and their measurements set and clear. The utilization of this tool in the fetal ultrasound clinic reduces keystrokes by 82%, resulting in shorter exam time, higher reproducibility among the team, and more operator-independent scans, which is not something we're used to in the ultrasound world, as it's mostly user-dependent. The next example is SonoABC follicle, used in IVF clinics. This is an automated tool using 2D and 3D imaging for automatic follicle counting and volumetric measurements in just a few seconds. This software is developed to assess simulated ovaries and generates a report that specifies the 3 diameters, the mean diameter, and the volume of each follicle. It organizes them in a descending order, and not only that, it color codes each follicle for easy identification and represents them in 3D, as we can see here. As we discussed earlier, a good 3D is built upon a good 2D. Follicles require some adjustments in the 2D for good visibility. Once that's achieved, the 3D mode is then activated. From there, SonoABC is selected, and shortly after that, we will see the same exact screen as we see right here. Once it's activated, it will appear alongside the detailed report that includes the diameter of the relaxed follicle, the lengths of the follicles in X, Y, and Z axes, and the follicle's volume. Again, this is another tool that simplifies the workflow with higher sensitivity and less working steps. The last set of examples we will have are pertaining to point of care. The first example we have is pertaining to portability. As you can see here, we have two different examples of portable ultrasound machines. The one to the right is a laptop style, and the one to the left is a handheld ultrasound. The laptop style machines have been improved with their batteries, so now we can have machines lasting from 1 hour to 3 hours. These systems can be used free as a laptop, or they can be mounted on a cart. Usually when they're mounted on a cart, it's because of more probe connectors or in cases of more accessories needed for that specific machine. However, these weighing between 3 kilograms to 5 kilograms are easy to carry between departments within the same setting, or even for mobile clinics as well. The other challenge that's been faced and resolved in these machines is having a very good image quality, even for a portable ultrasound machine. Looking to the left, we have the handheld ultrasound system, which is also called a pocket-size ultrasound system. The pocket-size ultrasound system is probably the same weight as your iPhone or smartphone. It's very light in weight, the design is super smart, and it's not slippery, so it's not easy to fall. Either design, they are tested for durability, reliability, and strength, and usually they are subjected to drop tests as well. Now, focusing more on the handheld ultrasound system, this is a new era of ultrasound. Now, with this one specific here, we have two probes within the same device. So a linear probe and a convex probe, or it could be a linear or a sector probe. And the advancements and innovations are still happening, and we will hear more about them in the near future. The nice thing about this one is it is wireless, so you can connect it to any smart device in the room. You can work on it in the street, for emergencies, on an ambulance, on a helicopter, or in any setting that you might be in. The good thing is that the image quality is increasingly getting better and better by the day as we speak. So even if it's connected to just a phone or any smart system, you can rely on these images very easily. The second and final example we have is CNerve. It is used for nerve block applications. This is a machine learning enabled tool used to facilitate the detection and tracking of nerves during the scouting phase in a nerve block procedure. This feature is enabled prior to the needle insertion to inject the anesthetic agent. Once scanning the intended nerve, select the CNerve from the screen, and then it automatically detects and highlights the intended nerves with a yellow color overlay as seen in this picture right here. In addition to that, and at the same time, the software provides a reference image and a reference clip. These are showing the anatomical target and the probe positioning to assist the users in acquiring the correct view as well as the correct probe orientation. Additionally, it displays a distribution map, as seen right here, corresponding with the anatomy chosen already from the presets. The CNerve can be combined with color Doppler modes, such as PDI or just color flow, which also helps and enables the users to identify the structures as they're viewing them. Nearing the end of our presentation, let's take a look at the future of ultrasound. This chart right here, done by the Data Bridge Market Research, summarizes the future of ultrasound in the Middle East and Africa. This forecast shows a great jump in the ultrasound market in our region from $1.17 billion in 2021 to $2.17 billion expected dollars in 2029. This great jump reflects the growing demand and need for ultrasound systems, which can be reflected to many factors, such as the rising prevalence for disease, more research and development funding, and finally, because of the growing investments in healthcare as a whole. The future of ultrasound as we can see it today is circled around three main pillars, and these are research and development, deep learning algorithms, and even better AI. These three can be enhanced further, and that can be done by coming up with novel image reconstruction methods, enhancing our automated imaging annotations to support with our deep learning algorithms, coming up with structured clinical cases introduced to and resolved by AI, and finally implementing more research to advance AI-based decision-making to support our healthcare professionals. Ultrasound have come so far already, and it is still needed to come further, especially being the real-time, low-cost diagnostic and screening tool that our patients deserve. Thank you all so much for listening, and I look forward to receiving your questions.
Thank you, Ms. Shuibat. Your exploration of the cutting-edge ultrasound technologies from elastography to AI-assisted imaging showed us how innovation continues to shape the future of ultrasound diagnostic imaging. So now we come to the most interesting part. I'd like to call back our speakers alongside with all our invited panelists who may want to share and add with the topics that were shared by our three speakers before we give them our questions. So far, we don't see yet any questions coming in from our audience. But we want to know if our panelists can have a sharing of their thoughts about practice of ultrasound and that important techniques that were shared to us by Sir here, and also about the technologies that may be prevalent and usually used there in your country. So while we are waiting, I think I have some few questions to our speakers. So to Sir Mustafa Aweiss. Sir Mustafa, are you there?
Yes.
Yes. So Sir Mustafa, what clinical conditions benefit most from using your probe pressure to move the free gas?
Usually, when we have a gassy patient, I prefer using pressure than usually in the emergency situation where the patients come in without preparation, without anything. So we have to use pressure to fast scanning the patient. And we see whatever we have to see without preparation. But if the patient, we can prepare the patient, so we can do a lot of things to prepare the patients before bringing him in, and then we can avoid gases also.
Right. So, listening from your presentation, it seems like there's so much the sonographer needs to find out and assess first about the patient, from habitus to conditions to even communicating constantly regards felt pain during scanning.
Yes. Yes.
So while we're waiting for, I think, some more other questions for you, I would like to jump up to Mr. Adham Abderrazeq. Sir Adham?
Yes.
In your experience, what's the most common error in performing echocardiographic imaging among new technologists? Can you share to us? And you think what training methods help improve orientation during performance of cardiac scans?
Okay, the final update of the echocardiography, we can be measurement the ejection fraction by Simpsons, and using the global left ventricle strain for evaluation, and estimated the coronary artery disease by eyeball. We can use improving some devices for see more evaluation of the regurgitation, evaluation the vena contracta and error of the mitral regurgitation, amount of the blood regurgitation volume in the mitral regurg can be evaluated by the echocardiography. The pulmonary hypertension estimated can be in an additional of add the artificial intelligent AI add of the echocardiography for easily and help us for evaluation of the regurgitation and other disease.
Will you agree that it's very hard to commit error during scanning, right? Especially for those who are new in echocardiographic scanning. If I may share, in Philippines, less radiologic technologists would want to venture and practice in the echocardiography. So critical concern may be, when there's AI and there's an ease of use of high-end modalities for echocardiographic imaging. Some healthcare workers would like to be trained and do the ultrasound echocardiography in Philippines. So I wonder if most radiographers also do have high interest in learning cardiac echocardiography in Palestine. Are you a number of radiographers doing echocardiography in Palestine, or there's also less radiographers doing it there in your country? Because in Philippines we have less rad techs would want to be doing the echocardiography. How about there in Palestine? So
what's What's the question?
I said that it definitely not acceptable to error, performing echocardiography. With new technologists, I ask you about what are their common errors as new technologists doing the echocardiography. In Philippines, it seems to be not an easy field of practice. That's why many radiographers would not want to do that exam or practice that exam. So how about in Palestine, sir? Were you many radiographers doing the echocardiography?
Oh, yes. A number of the echocardiographers do the echocardiography is limited in Palestine.
Yeah.
Hello?
Yes, we can hear you.
And the number of the echocardiography is limited in Palestine. There are mainly 2-3 only echocardiographers because the echocardiography is done by the cardiologist only in Palestine.
Yeah, I can understand. I think that's the same situation that we also have here in Philippines.
Yeah, BJ, I want to
Sir
comment on
Mohammed.
that. Yes, this year, Palestinian Ministry of Health granted permission to practice sonography in Palestine. So we have a little of practitioners. We have 2 or 3 sonographers who are graduated outside of Palestine. So this is the first time in Palestine we are permitted to practice sonography here.
Oh, really, sir?
Next year, I think next year the universities will have a specialized program for education sonography. But this needs some preparations here, and they need approval from Ministry of Education, Higher Education.
I think that's a good news, sir.
Yes, it is mentioned here in Palestine.
All right. So, of course, I also have a question to Ms. Sewar Shuibat. Ms. Sewar, which advanced ultrasound tool do you believe will become standard in the general practice within the next 5-10 years?
Hi. So this is a very wide question because, each area of medicine has its own examinations.
Mm-hmm.
So to give you one thing that is going to be the thing for all, I don't think so. However, maybe one button that's called automatic automation for image quality. This is probably going to be like the standard on all systems, which will improve the quality of images in one click. However, that's not a clinical application. So if we talk about clinical applications, I think the one that's going to have tremendous growth is the shear wave elastography, especially being FDA approved now for the liver, and it's on its way to being approved for the thyroid as well. So that's growing fast.
Wow, yeah, I would agree too. Same in Philippines. So we have now a growing demand for that procedure, the elastography.
It's reliable
and
it's non-invasive.
Yeah. Mm-hmm. Now, do we have some more additional thoughts coming from our panelists, or do you have any question or share of experience regards techniques and ultrasound or advancement in ultrasound imaging technologies or echocardiography? Because if none, we shall. Oh, wait, I'm seeing questions here. In our Q&A chat box. So I'd like to read from Sayed Sadat from UAE Dubai. A maximum frequency probe available in ultrasound technology, and what is the purpose? I think that would be for Ms. Shuibat.
Sure. This is another big question because when we ask about the maximum frequency, then we need to know what applications are we talking about. Mm-hmm. Because the higher frequencies we're going, it means the more superficial we're imaging. It's that relationship between frequency and depth. The highest in the market for clinical daily applications is 20 plus megahertz. But that would mean we're imaging superficial nerves and vessels for the most part, unless there is a different question. It's also being used for skin imaging sometimes, but this is very rare.
All right, thank you for that answer. I have here, it's the question is unclear here. I think you can help me explore this question from Mustafa Aweiss. Why do pressure the prop to the patient when scanning ultrasound on abdomen? So it's a bit unclear question, but let me proceed reading the third and last one here in the Q&A box. Sonographic Murphy's sign is one of the important features to diagnose acute cholecystitis by ultrasound. If we are advised to avoid applying additional pressure on abdomen, may I ask how to demonstrate the sonographic Murphy's sign? I think that is for our first speaker, Mustafa.
I think this is great because now if we have pain, why should apply pressure? Nowadays we have good machines. Like in the past, the machines are like the resolution, the contrast, and everything else. It's very very bad. And nowadays we have great machines and we can see things better. So applying pressure, I said, is connected to the gas and artifacts. We should not apply pressures like without any reason. So we have to have a good reason to apply pressure where we don't see. And if there is pathology, and we should not rupture things and cause more pain, we should not use pressure. And we scan as is. We don't have to. We don't have to do that. Okay.
All right, so I think with that, we have 3 questions that were answered already and some more questions addressed to our speakers. I think we're ready to wrap up today's session. So once again, thank you to our dear society presidents and to all our invited panelists who join us live here in the program, to our excellent 3 speakers from PAMRT Palestine, Professor Mustafa Aweiss, Mr. Adham Abderrazeq, and of course, Ms. Sewar Shuibat. Thank you so much for delivering such an incredibly informative and engaging presentation on ultrasound imaging and cardiac diagnostics. Your insights on using ultrasound probe pressure to move free gas, your cardiac echocardiography and ultrasound advanced tools and applications have greatly enriched our understanding of these critical topics. So this session not only expanded our knowledge, but also emphasized the vital role of radiological expertise in enhancing diagnostic accuracy and improving patient care. So we truly appreciate your time, your effort and dedication to advancing the field. As we all know that Palestine still is in a not so easy situation. But so before we officially close the program, I know everybody's excited to share a glimpse of what's coming next. Our upcoming CPD Asia program this month. We have another one coming up this month. And to announce that our next host will be the Taiwan Association of Medical Radiation Technologists, TAMRT. Please welcome President Chun Yuan-Tu to give his invitation to us.
Hello, everyone. The Asia CPD online course will be hosted by TMRT on October 18 at 1 p.m. Taiwan time. We hope everyone can join us. Thank you.
Thank you so much, President Chun Yuan-Tu. He's in Taiwan now, and we look forward to seeing you there for another round of learning and collaboration as TAMRT leads the 55th CPD Asia session on October 18 as part of the CPD Asia series. Thank you, President Chun Yuan-Tu. We shall save that date. So finally, we'd like to express our sincere gratitude for the support of the VT Healthcare Vietnam, to all our Zoom sponsors, Big congratulations and thank you to our host for this session, the Palestinian Association of Medical Radiation Technologists, PAMRT, to President Muhammad Abdul Ghani, along with all your officers and the PAMRT CPD Organizing Committee. We also deeply appreciate the ongoing cooperation of our CPD Asia IT team, the unwavering support of our presidents who are all here, and your officers who help bring you engaging CPD Asia sessions every month. And above all, we extend our heartfelt thanks to all our registered participants. We have here in the actual Zoom 243 people who have registered and who are here. And you made this online CPD Asia really, truly a success. So again, I warmly invite you to join us again for the next CPD Asia session this month on October 18. Once again, I'm Peachy Luna, your host, and saying thank you, everyone. We shall see you next week, October 18. Bye-bye.
Bye-bye. Thank you. Bye-bye.
Bye. Bye.
Bye-bye. Bye-bye.
Hi, dear Sir President Gex Subianto.
Yeah, thank you, Peachy.
Thank you for joining.
Thank you, Mr. Khan. Yeah.
Thank you, Madam Chan Lai Kwan from Malaysia.
Bye-bye.
Thank you for joining.
I was not feeling well, so I missed the first part.
We're happy that you are here.
Okay.
Thank you,
I
sir.
finally make it also for the closing.
Thank you so much, everybody.
Bye.
Keep safe, everyone. See
Heartiest
you next week.
congratulations
See you
to Peachy
next
and
week.
Park for this
Sir
resounding
Bhagwat.
success. And God bless all.
God bless all. Madam Cara now, Sir Nelson, Sir Jerry.
See you all next week, hopefully.
See you next week, October 18. Surely, Madam Chan.
Bye.
Bye-bye. Sir
Yeah,
Nelson
must keep myself
Hong
well.
Kong.
Bye-bye.
Recording stop.